Hello, everyone, and welcome to today's webinar from the Association for Vascular Access. We are excited to have you for today's presentation titled Protecting Your Patient and Vascular Access Devices from Sticky Situations, sponsored by Adhesive Biomedical. My name is Eric Sager, AVA Director of Communication. Now it's my pleasure to introduce today's speaker, Matt Ostroff. Matt is an advanced practice nurse working as the Vascular Access Coordinator and lead clinician for the award-winning hybrid ultrasound-guided bedside vascular access program at St. Joseph's Health in Paterson, New Jersey, specializing in pediatrics and adults. After earning the Outstanding Graduate Award from Drexel University in the Adult Gerontology Acute Care Nurse Practitioner track, Matt advanced his scope of practice working under the Chairman of Surgery. Matt is also a speaker for 3M, Biberon, BD, Vigon, Adhesion, and Sonosite. Matt has had the privilege of sharing his vision for vascular access, speaking throughout the US, Canada, and Latin America, with an emphasis on critical thinking with complicated cases to advance our specialty, as evidenced by his work and publications on the use of the femoral vein in the mid-thigh and subcutaneous tunneling. Matt, take it away.
I'm excited to talk to you today about vascular glue and to take you through some of my complex cases and show you where this fits in and how I kind of think through these things with my team. So without further ado, I will go through my disclosures really quickly. I'm the Vascular Access Coordinator and the lead APN at St. Joseph's Hospital. My team is actually probably more the coordinator. They do all the scheduling, they do all the management stuff, and I kind of get to play with all the complex cases. So a huge kudos to my team. We really work very closely together, and it's such a joy. I'm actually sitting at my new team member's house giving you guys this presentation. So I'm excited about that. I'm on a speakers bureau for all these different companies. But what I do with these companies is if I use your product in my practice and you want me to talk about my practice, you can sponsor me to talk. I don't necessarily talk about the product. So I'm really excited about sharing how my team and I work with vascular access, not really what the product does, but when the product benefits our patients, boom, here we are in front of you. My objectives tonight, I want to review today's patients and their vascular challenges. You know, we talk so much about the complications and how the nurses need to put the IVs in better places, but what we're not talking about is the patient population that the nurses are facing now. And what they're facing is a completely different population than was 20 years ago. Now we have the chronically ill patients that continue to come back to the hospital. And that's where the challenge is. Our renal patients are living longer. Their fistulas are lasting 15 to 20 years. Therefore, they're becoming vascularly depleted. Our Parkinson's patients, our neurologic patients, all of these patients, our sickle cell patients, even our cystic fibrosis patients, they keep coming back. And when they keep coming back, they have less vasculature than when they started. And this is why our floor nurses are challenged. And this is why our role has become so large in hospitals. So I want to talk about what those challenges are and how we can think around them. I want to define the components and the characteristics of tissue adhesive. When they asked me to start speaking on this product, I said, look, I use it, I love it, but I want to understand it more than just what it does. I really want to get to the nitty-gritty because that's how you help sell to your patients. You know, consent is so much more than permission for the procedure. It's convincing your patient that you are learned in your profession, that you're the expert, and that you really have selected the right device and the right products for that patient to get through their intended therapy. I want to describe the purposes of the tissue adhesive. Like, where do we use this? Is it just for site securement? Is it for catheter securement? Is it for hemostasis? Is it for making, you know, a seal on a tunnel? Where can you use this tissue adhesive? And analyze the financial benefits of the vascular access specialist having all these tools. Look, I don't like to talk about money and I don't like to talk about the cost of products because I don't think about that stuff. But I took a napkin and I drew this stuff down and I said, look, if this costs this much and all these products cost that, and I can eliminate 2 products with 1, then I'm going to save a lot of money. And this is how I kind of think through my new products when I bring them in. The other thing that I would ask you to do if you're trying to bring in new products is to tell your leadership that you only see 5% of the patient population. I mean, unless you're a 24 hours, 7 days a week vascular team, We have about 168,000 admissions a year, and my team sees about 8,000 of those patients. So when I ask for a product, I'm not asking for 250, catheters. I'm asking for a specific amount of these specific products that I need in special cases for 5% of the patient population. And when I present it to them that way and they go, oh, so there's only like 20 patients a year that you're going to use this special product for, then all of a sudden I'm able to get all the different pieces that I need. So, it's all in the way that you bring it to the table to present it. And finally, my favorite thing, I want to discuss the future possibilities of vascular access, because we don't even know what is out there. We are making advances every day to the point where, for example, now we can do percutaneous fistula creation. It's just putting a needle through the skin, going into a vein, guiding it into an artery, putting a wire and a sheath, magnets, and boom, you created a fistula at the bedside. Can you imagine when we start doing that? It's going to be unbelievable. And we're not going to use fistulas just for dialysis patients. They're going to be an artificial vein that we can use for anybody, for sickle cell, for cystic fibrosis, for MS, for Parkinson's, for your neurologic patient. Instead of trach, peg, pick, it's going to be trach, peg, fistula in my fantasy vascular access world. So our challenge right now is that for the last 30 years, 20 years, we've been focusing on central lines. They're invasive, they're in very sensitive areas, and we've been looking at how we can control those infections. Meanwhile, we've had over 300 million peripherals a year placed in the United States. 300 million. These devices have not been watched, and this is what our challenge is now. How do we protect those devices as we prepare for what's coming down the road? And what's coming down the road is we're going to be responsible for all bloodstream infections. What else are our challenges? Device stabilization, big problem. Hemostasis from the exit site, big problem with our central lines, right, and our PICCs. Visualization of the exit site. Man, the standards talk about visualizing the exit site. And the CDC recommends a sponge that covers the exit site. So you only see the exit site every 7 days. When are we going to match our standards with our recommendations? And is there something that will allow us to visualize that exit site? Maybe glue. Catheter removal and replacement. How many times have you been to a patient's bedside where maybe they have a mastectomy on one side? So you have a PICC line in and you need to remove it and they need a new one for whatever reason that may be. We normally put an IV in, right? We remove the PICC line, wait a day for the site to heal, and then go back. What if you could put a fake skin over that exit site and then move up and have a new insertion site? How cool would that be? Dressing securement. How many times do we have those obese patients with the rolls and the folds, or you have the patient that's very hairy? Sometimes, no matter what you use, securing that dressing down is just very, very challenging. But with glue, it's a little bit easier. Skin integrity. So many times, right, we get called into that complicated case and they're like, can you get a PICC line in or a midline or even an IV? And you go, yeah, and you find that little place of skin that you can get through, but under the dressing, you've got all that compromised skin. Well, what if you could seal that compromised skin with glue and then go into a safe spot so that there's no bacteria that's going to migrate to the insertion site? That's another exciting thing. And tunnel closure. We're bringing tunneling to the bedside, whether you're doing subcutaneous long tunnels with your needle or actually a 2-puncture tunnel. Closing the tunnel, which vascular surgeons have been doing with a type of glue for years, can now use an actually indicated surgical glue or IV glue, insertion glue, if they choose to. So very, very exciting options. Now, Dr. Helm wrote that article, right? Acceptable but unacceptable. A couple years, 5 years ago, 4 years ago, actually, I should say. And he said that a 30% failure rate was unacceptable with IVs. I'm sorry, 30 to like 50% failure rate was unacceptable. He wrote a follow-up in 2019. This just came out. And he said, in reviewing the recent literature to write this follow-up, 4 years later, the problem has yet to be solved with peripheral IV failure. Okay, this is 4 years later. We still have the same problems, but a lot of us, including you, I'm sure, are working on this problem. And one of the ways to work on it is to apply glue with your peripherals. So I'm not going to read you all of the specifics in the article, but what I am going to tell you is that what he highlights is that trauma and contamination are the two forces that are really creating the problem. Trauma, meaning the entry site to the vein, using ultrasound, you know, how deep, how long, how much purchase of the catheter are getting in. And then contamination from dressing integrity, from migration, from movement in and out, and from destabilization of that catheter. These are all the forces that are creating problems with our IVs. So what is skin adhesive? Skin adhesive is a cyanoacrylate, which is a liquid monomer, okay? Which simply means that it's this liquid stuff that polymerizes or activates when it's either in the presence of moisture or liquid or air. It just becomes alive. It's an exothermic process. It releases energy. And what it does is it kills everything in its spot and seals. There are 4 types of cyanoacrylates. They started out with methyls, and all it is, really simply, is carbon chains, okay? And the only reason I'm sharing this with you is because it's kind of interesting, because the methyls were industrial plastic bonding, okay? This was your strongest glue, but it wasn't flexible, and it was very difficult to use in any other method than industry. Then they came out with ethyls, which was a 2-carbon chain. These were your crazy glues, and believe it or not, physicians were using crazy glue on patients, completely off-label. Then we came out with the N-butyls, which was a 4-carbon chain. These were the earliest topical medical adhesives. They were quick drying, but they were brittle and a little bit rigid, and they took 24 hours until they were water resistant, and they also released heat, which caused burns. And then finally, we got to what we're using today, which is a 2-octyl carbon chain. It's an 8-carbon chain, and these are your ones that you'll see in your operating room area. I won't say the names, but they have a higher tensile strength. They're flexible, there's less heat released, and they're immediately water resistant. And they're really easy to use, and that's why. Let me help you guys. The way I look at vascular access is it's a giant puzzle right now, okay? But it's a puzzle that's spread out. And what we're doing, what it seems to be that we're doing, is slowly pushing the puzzle pieces together, okay? For example, the glue has been in the OR for 20 years. And now we're saying, oh, wouldn't it be a good idea to, if we seal surgical sites, to seal a puncture site in the skin? Like, it makes total sense. It's not rocket science. But it's taken us 20 years to take the glue from sealing wounds to sealing a wound that we create with vascular access. I mean, it makes no sense that we would leave an open wound with a catheter sticking out the skin and not seal this site, no matter what you put on top of it or around it. Why wouldn't we seal that skin? And, well, like tunneling in interventional radiology, we can do this at the bedside. Why don't we take the tools from IR and put them into our toolbox? We did this with navigation equipment. Why can't we get rid of fluoro and bring in ECG navigation, just like we would with pacer wires in the emergency department when we thread a transvenous pacer? We're slowly taking from all the different silos of the hospital and putting it into our vascular access toolbox. And that's how we're advancing. That's how we're making magic happen at the bedside. And that's why vascular access is so exciting today. The end. Good night. No, just kidding. Here we go. There is no impact on catheter materials. They studied 12 different PICC brands, and it doesn't change the material that the PICCs are made with. So that's super exciting for you guys. History of skin adhesive. It's really cool. In the 1940s, Dr. Harry Coover, he invented this formula and figured out that these two things stuck together. And just like any genius in their generation, they shelved his formula and put it away. Not until 6 years later, His formula was revisited, and it happened by accident where they took this costly equipment and accidentally it got glued together with his formula. Then in 59, not another 11 years later, they took it and made the application of the super glue, and that's where you saw the guy with the helmet and the steel beam, and they glued it to his head and lifted him up. That's where they came out with that first glue, and it was on that TV show, I've Got a Secret or something, and they lifted the host up. Then in 1966, in the Vietnam War, they brought the glue in for the soldiers, and they were gluing their wounds. But the problem was, again, this was a methyl, and it was releasing heat, and they were getting really terrible burns. So they took the glue off the market for medicine. 79, the N-butyls came about, and it started being used again in the US. Not until 1997 did what you guys know about, and I'll say it, I don't care, of Dermabond, because it's written on there, they got their CE mark. That's 1997. And then in 98, they got the first 2-octyl blend, and that they started using usually in hospitals for wounds around the eyes and superficial skin stuff. And then they started with another glue that you'll see there. And finally, in 2008, they came out with a product called Surgiseal. And what this was a product that you could paint onto the skin that would clear all the bacteria. Kind of like Ioban from 3M, the yellow thing that they put on and then they cut through. So what I want you to put in your head is that the Surgiseal that kills all the bacteria, like the Ioban, okay, like the drape, like a liquid drape, is the same formula as the glue that we use for vascular. So if you want to think about this, the same claims that they have are the same glue that we're using on the IVs, okay? And I'll let you guys figure out what I'm trying to tell you on your own. Application and removal. Guys, it is so easy to use. I remember when I brought it to the hospital, they said, how are the nurses gonna learn this? And I said, really? You turn it upside down and push, and then you turn your hand around and squeeze, drop, drop. It's so simple. You put a drop around the insertion site, a drop under the catheter where it links up to the hub, and you can smear a little bit around so that the dressing sucks onto it, and that's it. You've got instant stabilization, and it lasts up to 7 days. Removal is simple. Everybody says, well, how are you gonna get it off? How are you gonna get it off? How do you get anything off? If you use the other Securement products, like the product from, like the products that you, I'm trying not to say the names, that you smear around the skin that help the dressing adhere, well, you need a product to help those come off too. With my team, I always tell them they have to prove the device that they chose based on the available vasculature. And what I mean by this is, if you're going to simply need an IV and you put a midline in, you have to prove to me that they didn't have veins in the forearm. And if you need something greater than that and you put it in the forearm, I have to understand why you didn't use the upper arm veins or a PICC line or a central line. And what we've done is we've tracked all our data for the past 5 years. And I just have the last 3 years up here. And what it's shown me is that 75% of our patients, 70 to 75, have a cephalic vein in the forearm. Why is this amazing? The cephalic vein in the forearm is the perfect vein in your body. And it's the only vein that comes with a built-in stabilizer. You have the radius and the ulnar bone, and they don't move unless, you know, they get hit by a baseball bat. So they stabilize that catheter in place in the mid forearm, and that's why we're getting extended dwell times. Anybody that lectures to you on extended dwell peripherals, the only time that you're going to get that dwell is in the forearm or the upper arm, you know, if you're using a midline. But in the middle of the arm, in your mid forearm, is where the sweet spot is, and you're going to get that dwell. So 75% of our patients have that. And by proving that, I was able to show our administration that by putting a long peripheral IV and showing them how much that insertion costs versus a midline, versus a PICC line, versus a central line, when appropriate, that we're being fiscally responsible by putting in, we put in about 400 ultrasound guided IVs a month. So if we put in 400 of those IVs versus 400 midline / PICC, we are saving a ton of money, where let's say 10 peripheral patients are equaling 1 midline or 1 PICC line. And what that does, because the average length of stay is 5 days in our hospital, our peripheral is lasting the entire course of therapy because our average dwell time is 7 to 12 days. So we're doing 1 stick per patient when we're called. So we're saving a ton of money that way. I'll just show you real quick, 71% in the forearm, 14% in the antecubital. Now I know the guidelines say avoid areas of flexion, and I agree with this, but you have to learn when to use the guidelines and when to use your brain. If you have a patient that is getting a same-day CT scan, same day, in and out, and they have a beautiful antecubital vein, are you not going to put the 20-gauge catheter there for their CT scan because it's in an area of flexion? Can they not keep their arm straight for 1 hour to get their CT scan and then pull it out? Are you going to call a team to ultrasound guide something into the forearm for that? No. So there are certain circumstances where going in the AC is great and it's fine. And you need to look at those cases, you know, if they're in an infusion center and they're just coming in for an infusion every 2 weeks, these are different circumstances than your patient that is sitting in the hospital. And we really need to learn or to apply our guidelines to each patient specifically based on their circumstance and not based on vascular access. It has to be, why are you here? Are you getting 6 weeks of antibiotics? Yeah, you're a different case. Are you here for an hour? You're a different case. Are you here for 3 days? You need a different device. It should be individualized, and it shouldn't be this algorithm of what it is. It should be based on what their available vasculature presents. 6% in the brachial. Guys, the brachial is the best vein in the body to go for in a rapid response. The best vein to go for when you need to bridge a patient to a PICC line or bridge a patient to get to interventional radiology or to their vascular surgeon. The brachial vein is always, I would say 98% of the time, next to the brachial artery, and it's big enough to cannulate. And it's, of course, the nerve is there too, but you can get around it. It is my go-to vein in an emergency. And if you take it out within 24 hours and put another device in, it's an amazing bridge. So we can then use areas of flexion as a bridge to the appropriate device. For example, Friday afternoon, 5 o'clock, your service ends at 5. Patient needs a PICC line. They're not being discharged till Monday. You can't stay. What do? Ultrasound guide and IV for the weekend, pick them on Monday. It's a bridge. You have a patient that needs to go to IR because you can't, they're just contraindicated, let's just say, that you can't put your device in. You can ultrasound guide an IV in and bridge them to get there so that you never have to say no. And by not saying no, you don't leave your patient without access. Because you really, when you're called in, you're the last resort. When you walk away and say, we couldn't do a PICC, what do you think happens to that patient? They wait. They wait until the person that can do the PICC comes because nobody else can do the IV. So you have to leave your patient with a bridge. 2% to the basilic. I'm not a big basilic fan. It's a little deeper, guys, and it makes the catheter bend, and they usually kink and stop giving you blood draw. I saw on that vascular site that I always get in trouble on, I saw a post, I think yesterday, and it said, how do you get midlines to stop not getting blood return, to stop not getting blood return? And I wanted to write in, don't put them in. Midlines are just, they're just hit or miss. You can have the biggest vein and put the best midline in, and the next day there's no blood return. You could have the best vein and put in a midline and you get blood return for 3 days. It's just not something that you can guarantee. And that's my problem. My problem is I treat my patients like my family. And if my mother was in the hospital and she needed 5 days of reliable blood draw and access, the truth is I can guarantee her her PICC. I can't guarantee the midline. I can say it might work, but I can't guarantee it. And that's my only issue with midlines. 7% to the cephalic. We all know cephalics are bad news. They're bad news for DVT, and I'll tell you why. So the cephalic vein, if you do angioplasty or venograms, you'll see the cephalic vein goes up your shoulder, around your chest, and then makes a steep turn into the subclavian vein. That's why the cephalic vein is bad. It can look good in the arm, And then when it joins into the subclavian, it makes the steep turn, and sometimes it's really, really narrow, and you can't see that in the arm. And that's why those PICC lines are notorious for getting DVTs. So just a little insight I'm sharing with you there. If you guys were on my website, or when I got in trouble on the other one, I did an experiment with the glue. I wanted to see how long does this stuff really last? Will it work with water? And will it really secure my lines? So I glued I didn't glue it. My team glued a catheter to every part of my body: mid-thigh, subclavian, jugular, forearm, upper arm. And I showered for 7 days with these in place, and I pulled on them every day, and guess what? They did not budge. And what I recommend to all of you as clinicians, if you have a product that is non-invasive, that cannot hurt you, try it. Experiment at home. Don't wait until you have 50 patients that you put the Tegaderm on to see how it comes off. Stick it on your own arm, look at it for 5 days, and take it off. And when you want to test the adhesive removers, use each adhesive remover on a different dressing and test it out for yourself. You can learn so much about your products without doing these studies and trialing this stuff. Really play with this stuff on your own. For example, there's a silver disc now, a silver impregnated disc. I want to see how it works. I want to see if it leaves the same ring that the CHG impregnated disc leaves when you leave it on for 7 days. So guess what? Am I going to put it on a patient and go back to them in 7 days and see what it is? No, I'm going to glue it on my arm, and I'm going to glue another one on my other arm, and I'm going to take them off and compare the two after 7 days. And then I don't have to get permission from the IRB or consent a patient. I can look at a sticker and a patch on my own skin. There's so many products, guys, that we put on patients. For example, a sticker device, all the different dressing things. You can put them on yourself, and if you don't want to torture yourself, put it on your significant other and see how it works. And you will learn so much. When I put the PICC line on myself and glued it, I actually learned that you don't notice the PICC lines there. It was unbelievable. I actually didn't mind having the PICC line on. And now I can tell patients, I don't know what it feels like inside, but it didn't bother me at all, even when I was getting dressed and moving around. So I learned a lot from that experiment. Stabilization. Let's get back to the glue, okay? These are 4 different stabilization devices. Sutures, adhesive securement, and then there's the subcutaneous securement device, okay? Guys, all of these products are good. They are all useful and indicated in their right scenario. And that's why I advocate for having everything on your cart, because you never know when you have that patient without skin. If you don't have your epidermal layer of skin, you have to go below the epidermis. If you have a skin allergy to adhesives, you need an alternative securement device to hold it down. If you have a 16 French catheter on a patient that is moving all over the place and for some reason they're in detox, whatever, you want to lock that in, and you might want to suture that line, even though it's bad. But how do you make a suture good? What if you seal the suture sites with glue? That would make suturing not so bad, right? In my opinion. So all of these are necessary. And what they did when they did a pilot on tissue adhesive on peripherals, they found that they extended the dwell time from 35 hours to 73.2 hours. This was a big deal. And then the company said, they started saying, we can double your dwell time with glue. And I said to the company, you can't say that. That's not true. You can't say that to an account. And then I thought about it, and I said, you know what? What if you took that IV that you put in the thumb in the ER, where that emergency room nurse saved the patient's life, and you glued it, and it didn't piston on the thumb, and instead of it lasting 1 hour, it made it 2 hours. Well, then you are doubling the time. And in that extra hour that thumb IV stayed in, you were able to get a central line in, or a PICC line, or an ultrasound guided IV. So yes, you can double the dwell time. It might be minutes, it might be hours, it might be days, it might be weeks. But whatever it is, it's long enough to get what you need done. And that's what kind of blew me away when I started to really think about it. And then I said to the company, Okay, I'm on your team again. I'm sorry, I think it's a video. It's not. PIVs and midlines. I say, can we just call them all peripherals? Anything below the axillary vein is a peripheral IV. They're just different lengths. They're different gauges. You should base your device based on the vessel, the location, the depth, what gauge you need, what products are going in, and how much purchase you need into the vessel. That's how you decide what device they get. It's not they need a peripheral, they need a midline, they need a PIC. It's length and depth of that vein to get what you need done based on their treatment that is ordered. So it has to be specific to their treatment. You're not going to give TPN through a long IV. And what they found here with the glue, with the dressings, was that in all 4 types of dressings, whether it was an integrated securement device, whether it was a sutureless, that's what the thing was, a sutureless securement device, whether it's a subcutaneous device, there was a reduction in the dressing integrity of having to change that dressing by 80%, by 71%, by 50%. The average time to first dressing change was 2 days longer in these patients that would otherwise usually be compromised. And ever since we started using glue on our insertion site, we have not had to go back to do an early dressing change. In fact, there were 2 weeks where we didn't have product, and we found ourselves getting called back to the floors, and we were kind of, our mind was blown. We were like, gosh, this hasn't happened in so long. Okay, we won this Healthcare Hero Award for New Jersey. And we won it because in 2014, I said, I don't understand why we're putting in ultrasound guided IVs, like IVs, but we're putting in ultrasound guided central lines sterilely. Why aren't they the same? And I didn't understand it. And I started putting in sterile ultrasound guided IVs. And of course, since 2014, this has kind of developed, and now people are doing it, and they're putting together procedure kits, which saves so much time at the bedside. And we're all putting in sterile ultrasound guided peripherals. Why? Why do they have to be sterile? Because ultrasound guided peripherals can have an extended dwell time. But I don't believe in extending the dwell time unless they're placed sterile. So I don't believe in going to clinically indicated site rotation unless you're placing your devices sterilely. That's my thing as a clinician. It's got to be sterile to stay in. And we're seeing dwell times of up to 50 days sometimes. So sterile insertion, clinically indicated site rotation. Here are some peripherals. This is a patient with, a 20 gauge peripheral that was going for a CT scan. This is a little pediatric baby with a 24. And here on the right, probably your left of the screen, is an exciting one. Because I do pediatrics and adults, when I go to do a central line on a pediatric patient, I put in a 4 French double lumen 8 or 13 centimeter catheter. Okay, 4 French double lumen 8 or 13 centimeter. What is that in an adult? It's a midline, right? So this is an adult that needed heparin and antibiotic and had very small veins, and I can't remember why, but we weren't able to go central. So I put in a 4 French double lumen coated catheter as a midline. That was a pediatric central line. Now I know that's off label, but it makes no sense. A catheter is a catheter is a catheter. There are no difference in your veins from when you're a baby to when you're an adult. Okay, so whether it's small, big, skinny, double lumen, triple lumen, quadruple lumen, or a 26 gauge, it should be able to go in anybody's vein. And one day, I hope that catheters will be labeled as clinically indicated catheter placement. And then you can choose the right catheter for the right patient at the right time, when we can choose any catheter that's appropriate for the patient. Okay, this is a gentleman with pemphigus, and it just so happens that my partner Jen Albano, who's sitting next to me, had a pemphigus case too. And what we did with these cases, where we used a subcutaneous engineered securement device, but what I did was secure the skin and protect the insertion site with glue. So this patient actually was found in the hallway in the ICU, crawling like Tales from the Crypt with blood everywhere. He ripped everything out. So they get him back in the ICU bed, and they're like, we need another central line placed. And I said, look, he's flapping all around. Let me get you 2 peripherals so that you can stabilize him, and then we can put in a safe, clean central line. And that's what we did. I put in 220s as a bridge to sedate and stabilize, and then put a clean PICC line in for him because it was going to stay in for so long, and then anchor it with the correct securement device because he had no skin. This is a baby up at the top with Netherton syndrome. Netherton syndrome is another kind of skin condition. It's almost like a red man syndrome, but this is a chronic condition that babies can have, and the skin just sloughs off and they have Vaseline all over. So I was able to clean a portion of the skin, but their skin is constantly contaminated. So I sealed it with glue because he was less than 2 months and I couldn't use a patch, and I had to put a central line in because he was septic and crashing, and he's doing great today a couple years later. This is a patient with broken skin that I had to do a jugular line on. Now I could find my way in, but I wanted to protect all the skin around it. So I glued all the open areas and created a fake skin over them, and then was able to put my catheter in safely without worrying about something, some open skin under my dressing. This is a patient with a mid-thigh femoral, and you guys probably know about my mid-thigh femoral work. Now, when you're scanning the leg, the femoral vein and the femoral artery wrap around each other. And sometimes you only get a small area where you can actually visualize the femoral vein to puncture. And it just so happened that that site was right next to that area of skin abrasion. So I covered the skin abrasion with a fake skin. I sealed it, and then I was able to put my catheter in safely. This is not rocket science, guys. This is a simple application of there's a problem, seal it, fix it, do it. Let's see, catheter removal and replacement. This happens all the time. This patient, which you'll see with a 20 gauge, was sent down to CT. The IV infiltrated. So they call us to put in a new IV for their CT scan. But what are we going to do? We couldn't use the other arm because there was an AV fistula, okay? So what I had to do was remove this catheter and put in another one. But if I just took it out and put in another one, there was going to be like either weeping or oozing or an open site under that dressing. So not rocket science. I removed that catheter. I sealed the old insertion site and was able to go a centimeter above it and put in a new catheter. Such an easy fix, and get that patient their CT scan. And then based on the results of that CT scan, we can either keep them in the hospital for one more day with that IV catheter, or put in the appropriate device to get them through their intended therapy to fix whatever was diagnosed on that CT scan. It's a bridge. Here's a patient that had a femoral line that I was replacing. Instead of putting another dressing all in his groin hair, that sounds so much better than pubic hair. I'm gonna call it groin hair. In his groin hair, I was able to just glue the insertion site so it wouldn't get dirty. This is another patient who had no other access site than this femoral area, but I had to remove his triple lumen in order to put my catheter in because they thought his was infected. So what we did was we put 2 peripherals in the arm as a bridge to continue his blood transfusion and medication while we put in the mid-thigh femoral line, tunneled mid-thigh femoral line actually, and then remove the peripherals. Guys, sometimes it's a puzzle. You know, we're all about one stick, and that's fine on our general patients. But on our complex ones, sometimes we can do 3 steps, and those 3 steps make the procedure that much safer. Example, I had a pediatric a couple weeks ago. They said, can you replace the IV? I said, of course. I go in there, the IV is still working, but it's just not great. The kid is hysterical crying, the mother's upset, and I said to them, what is this for? Well, they need to be sedated for an MRI. I said, so they said anesthesia is going to be downstairs, and then they're going to have their MRI. So I said, look, no, the IV is not great, but why don't you take them down, have anesthesia sedate them through the bad IV, take it out when he's sedated and put in a new IV, and there's no crying, there's no drama, and the child's not traumatized. It's not rocket science, but sometimes we can think through things and think down the road of how we can use the next steps to solve the problem that we have now. And the problem we had now was we needed a new IV, and the solution to that was we could use, I see that, I'll remind myself later, and the solution to that was using anesthesia to sedate the child so that he would be okay. I don't know, that's what excites me about Vascular is coming up with a plan, because we are better than technicians. We are more than just people that stick it in. We are people that think, and we think about how to get it in the best way. This is a cool case up at the top. This patient, obviously you can see, I'm sure you could guess, the nurse did a dressing change, CHG, didn't let it dry, put the dressing on, and you can see the skin irritation, right? So I was called, the arm was all swollen, and at that point she had had the pick in long enough, and I said, look, we have to remove that. So we removed the dressing, removed the pick line. Now how is that skin gonna heal? Because I'm gonna have to put gauze and another tegaderm on it. But instead of that, I sealed the exit site with glue, and I was able to let the skin breathe, let the skin heal, and put the pick line in on her other arm. You know, it's a simple fix, but it's something that we couldn't do before. We didn't have a fake skin that we could put on people, or we did, but it was super expensive and we had to go get it from the ER. Guys, why do we bleed from our devices? They have coagulation disorders. I put a tunneled catheter in a patient today, tunneled jugular with a platelet count of 45. Would IR do that? Probably not. Why can we do that? Because you and I have ultrasound and we have good hands and we assess to make sure it will be a successful procedure. Coagulation disorder, pistoning of the catheter causes hemostasis. How many times do you finish your pick line? You hold your pressure, you let it go. You celebrate because your navigation system told you you're at the cavo-atrial junction, and you go to get your securement device and you lift up the pick and it starts bleeding again. And you're like, oh, so you clean it again, you hold pressure, you play this game over and over. But if you could just put one drop of glue on the exit site, it will not bleed. Skin nick. Guys, how many people have felt bad when people say, oh, you shouldn't nick the skin, you should just pre-dilate and jam that thing in? Or if you're lucky enough to use a company that has a zero transition dilator, you can use that one. But if you seal the site, then skin nicking might not be so bad anymore because you're actually now sealing that site and protecting it from bacteria. So I do love Jack, Dr. Ledun, who says, the skin is the barrier to infection. I say, Dr. Ledun, I agree. So if I glue it and make the barrier, then my glue is the barrier to infection for those of you that need to make a nick. And sometimes it's actually better for the patient to make a nick instead of jam something in their neck or when you're doing a dialysis catheter. Yeah, you can do it, you can dilate up, but it's a little bit easier sometimes to make that nick sometimes. Need to create an opening in the skin. That's another reason we have bleeding, is doing a tunnel and creating an opening to make that tunnel happen. So these are all your products that you have on the market to stop bleeding. And guess what? They are all great. I recommend you use them in the right situation. But there's also one that is clear and invisible that will work as well. Sometimes you have to create hemostasis first. So the one thing the glue will not do, the glue will not, if you're bleeding and you drop the glue, it will not stop the bleeding. The glue simply seals the site after you've achieved hemostasis. So sometimes if I have somebody with a severe coagulation disorder, I will use that special gauze that you see up there, or that cardboard one that you see down in the corner. I don't use that patch up in the upper left corner. The one that you see down there, yeah, I'll use that one, the powder, without saying the name. Sometimes I'll put the powder on, achieve the hemostasis, wipe it off, put a drop of glue so that I can see my exit site. The only issue with all of the products that I've shown you is you can't see your exit site when they are on. So this is the best slide that I have in the whole presentation. This is the only one you have to pay attention to. So infection prevention by immobilizing and killing bacteria. Guys, these are your protective devices. The patient in the middle had a CHG allergy. She was one of my cystic fibrosis patients. How am I going to protect that line? These are the most immunocompromised patients almost that you have, cystic fibrosis, and an infection can kill them. So I was so scared. So I decided, you know what? The only thing I can do and put on her is the glue. So I put the glue on to protect her site. And for 2 weeks, no complications. And I've done this patient 3 different times with the glue, no problem. Now, here's my thing. When we're talking about infection prevention, and let me just go over the data with you really quickly. In 2017, Prince published an article, and what it proved was that there was a greater than 7 log reduction of gram-positive bacteria. Now the CHG patch is tested to a 4-log reduction. This was the first cyanoacrylate that was effective against both gram-positive and gram-negative bacteria. There was another study done, and what they proved was that it creates an impenetrable barrier to microbes, killing all of the bacteria that it comes in contact with within 3 minutes, okay? It's been proven effective against gram-positive, negative yeast and fungi. Or fungi, however you want to say it. Why do I bring this up? My CHG allergy. You can't use CHG in less than 2 months of age, and you can't use CHG on people that are allergic. So I say this, if anything, bring in the glue to protect your neonates less than 2 months of age and protect your patients that are allergic to CHG. If you see results in that patient population less than 2 months and people that are allergic, use those results to prove to you that this is as effective, if not more effective, than CHG. But you don't have to do a randomized controlled trial. You don't have to do a test. You don't even have to, quote, experiment outside of your policies and procedures of your hospital, because you already have patients that you can't use CHG with. So if you can't use CHG with those patients, use something else to gather your data, look at that data and compare. And if they are the same or better, then you know how you can move towards a different product if you so choose. Does that make sense? I like to look at moving to new products as not changing the standard of care that I'm doing right now at the hospital, but to apply it into different patient populations that have no standard of care. That way I'm not changing anything, and I can get the information I need and apply it and then change safely. That's just the way I do things. So the conclusion was that within 3 minutes, everything was dead with a greater than 8-log kill. All right, guys, that's big. How small can you go? Neonates and infants. This is what sold me. Guys, when you get a new product, I implore you to read the literature on not only that product, but its competitors and the case studies that are involved with it. When I read these case studies on these neonates, where in case studies 1 and 2 and 3, actually, they had an ostomy site. And what the doctors did was they put the glue over the ostomy site and the tissue healed from underneath, okay? Case number 4 is a patient with a gastric tube, and they secured it with glue and the skin healed from underneath at the ostomy site. In cases 5 and 6, there's a patient with influenza, and they had such irritation from the diarrhea that they actually put the glue over the irritated skin, and it healed from underneath. All right, so here are my NICU cases. I just want to show you a quick video. Before my video, let me take you through Dr. Pitteruti. Dr. Pitteruti, for those of you who don't know, is like Ava's vascular surgeon of the year, of the world, of the century. Who does all the complicated cases on babies. And anyway, he published an article on his use of glue. And what he did was he put the glue on the insertion site after he finished, and for 7 days, the glue stayed on, and then the nurses did a dressing change. And he had 4 components to add to his procedure. 1, he said you have to use ultrasound. 2, he believes in tunneling these catheters to reduce the bacterial load. 3, he loves glue. And 4, he believes in simulation-based training, because it's the repetition, it's the muscle memory, it's knowing your procedure kit that gets you through the complicated cases. And what he saw was a mean dwell time of 2.2 days longer with the dressings, okay? A 90% reduction in his catheter dressing change days, and in BSI, a rate reduction from 15 per 1,000 to 1.5 per 1,000. That's huge, and that's from a really respected surgeon. So here's a video for you. Oh gosh, before the video, just when I think nothing else was going to happen to me, and I'm like, okay, we're done. I made it to the top of whatever I can learn. We had a NICU baby, and the only vein that we could puncture was the axillary or subclavian vein. And this was a 1,300-gram baby. Scared out of my mind, brought the chairman of the NICU in and said, look, this is the only thing we can do. And I showed him on ultrasound. Here's the subclavian vein, artery, here's the lung pleura, here's the ribs. I said, I know we can do this safely, but I need your permission because, I mean, this is kind of really outside of the box, at least for the NICU. And he said, okay, Matt, looks good. And he walked out of the room. I was like, no, Dr. Zhao, come, please, stay with me. But he left, and we had a successful line placement because we planned it out. I must have scanned for about a half hour to make sure that it really was the vein. And this NICU baby made it. So here's a cool case, I hope. Yes.
Okay, so we have a 1,300 gram NICU baby who's going to require central access for TPN administration. The extremities have been exhausted by the nurses and the staff so far, so we're going to do a femoral line. We're going to start it with a 24 long IV. The wire through that, use a 1.9 French catheter that we're using now. It's got a great stylet. We're going to bring the stylet out to the end, and we're going to pull it back to 1 centimeter up the PICC line. Right there. That'll leave a little floppy in the front, and it'll stiffen our catheter to make our journey. We'll illustrate this through pictures and provide this child with central access.
Right up to the right atrium. How cool is that? I make these videos so that I can show the physicians what we really do. It's so important because a lot of times they don't get the full procedure that we do. They think it's kind of just like their central lines, but when you show them all the steps that are involved and how delicate and complicated the work is that we do, they start to appreciate, you know, what we do more. So here are 2 articles that describe the use of glue with a jugular line and an axillary CVC. They promote tissue adhesives for securement for all of these. I will point out to you that you'll see in my pictures, these are older pictures, I have a patch on top of it and I do have a sticker device on it. Our hospital has just approved the removal of the sticker device to just use glue. And what I do is I outline the sticker device in glue. And then the tegaderm adheres to it. We don't have approval yet to remove our patch, but there are several hospitals doing trials right now, and they are not using the patch, and they are having amazing outcomes. And my ID physician is just waiting for their publications. And I advise you all to be cautious with this. Always wait for publications. Always do the due diligence that your patients deserve when you're using a new technology. But like I said, when you have a less than 2-month-old baby that has no securement, no protection, why not use it and see if your rates drop or see if they stay the same? Because that will prove to you that the device works, and then apply it to your adults. What do we have here? 75 days of antibiotics. And what I'm seeing now, and this is just me, this is not the standards, I think PICC lines are going to be for 2 to 3 weeks. And I think tunneled catheters are going to be for anything longer because you can tunnel it and dress it on the chest, which is a really good place to secure and dress your catheters and protect them. Not only that, but you're putting it into a gigantic vessel. And what is the problem with PICC lines? 60% we have documented silent DVT. So just like our central line infections were a problem, just like our peripheral IVs are a problem, our PICC lines are a problem that we are accepting. We are accepting this DVT rate. We are accepting these things. And I think there's a better way, but the problem is scope of practice. And now I think we've proven that our vascular access teams need it all. We need the nurse, we need the advanced practice nurse, we need a physician, we need a PA. We need the ability to give the patient, when you go home on a long-term milrinone drip because you can't get an LVAD or a heart transplant, you should have a tunneled catheter to your jugular, not a PICC line for 6 months of milrinone, okay? We can now put the right device in for the right patient with the right vascular clinician at the bedside. And for people that are expanding their scope as a nurse, bravo. And for those people that are challenged with expansion, go to school and get your next certification, your next level up, and get the scope that you want. You can have everything you want. You just have to work a little harder than the person in the state next to you that has the privileges, okay? Sealing the sites with glue.
Okay, so what we just did was we had a patient who has been pulling out all his lines. He's contracted. He's going to be put on a morphine drip for hospice care. So what we did is we entered into the jugular and we tunneled out to the back, securement device, just to protect this site. And there we have it, a tunneled single lumen to the back jugular.
All right, isn't that super cool? Here are my tunneled mid-thigh cases. Just to show you that at the lower left-hand corner, that's a NICU baby with a 43-day dwell time with no complications. And our longest adult is 53 days. Here is glue used to secure dialysis catheters. This, though, I have to show you, securement on arterial lines. Here is a NICU baby with a 24 gauge in the femoral artery. There is a regular adult arterial line secured with glue. And here is a left axillary in the PICU that we use. Okay, but you've got to see how this glue works. You just have to see this. So stay in your seats just for 2 more minutes.
Catheter. We're going to do an outline with the glue. We're also going to cover the insertion site.
It's super cool.
We'll secure the dressing. Okay, so we're going to label this arterial line because it's good for venous and it's good for central. So this one will be arterial. And our nice little waveform.
Now you're going to see how strong it is.
All right, and we're just going to cover it with a bio patch, which we hope to eliminate one day, and an antimicrobial 2% CHG Tegaderm.
Oops.
And this will secure the leader flex, the arterial line.
Watch this. We're going to tug on it.
All right, this is securement.
This is an arterial line I'm tugging on.
It's not going anywhere.
Is that crazy?
4 centimeter leader flex.
Is that crazy?
It's crazy.
It's crazy. That's totally crazy. Here are all different situations where you can use the glue. I finger paint with the glue around the edges, and it holds the edges down really nicely. There's a hairy guy in the middle. Skip that one. Okay, we're at the last slide, guys. The future of tissue adhesive. I have no idea. I put them in my pocket, and every day I walk around, I find a new use. Taking an IV out when they have 3 IVs up the arm and you're going to go do a procedure. I take all 3 out, I glue the site, and then nothing bleeds. And then they don't have more stickers on their skin. Patients where the dressing is folding up. Patients where they're diaphoretic. You just never know. There's so many different uses. And I think it's going to be used for like nephrostomy tubes and anything that needs to stick. Okay, that's really what the future is. And the fact that you can see through this and that it's invisible, is, to me, the key. So I thank you guys for your attention. I have this picture up here because Dr. Ledun is who taught me. He is my idol. And I say to you guys that people who say it cannot be done really shouldn't interrupt those who are doing it, because we can't advance unless we ask why. I want you guys, if nothing else from this talk, I want you to go into work tomorrow, go to the bedside, and just ask why, to make sure that what you're doing is what you want to do, because we can change what's going on now. We can make developments, we can push this needle forward, and you're all part of it. So I hope one day I'll meet you all in person, and thank you for your attention.
Thank you, Matt. That was awesome. Appreciate it. Now, we do have some time for some questions. Matt, the question is, how did you get administrative buy-in?
Very, very good question. We got administrative buy-in for the glue for two reasons. One, we were returning to the bedside to do dressing changes from bleeding. So usually after your procedure, right, you do a PICC line or something, the patient gets up to go to the bathroom. And when they get up, they flex their arm, right, to push off the bed, and it always starts bleeding again. So we were spending then the nurse's time and a dressing change kit to do that. We were also holding pressure, for, sometimes 5 to 10 minutes at the end of the procedure on coagulopathic patients. So originally we just brought it in for hemostasis. It was just brought in to speed up our procedure time and to protect the insertion site from bleeding. And then as I learned more about the glue, and as we started playing with it more, when I say playing with it, I mean using it for different applications, it became so vital to the procedure that when we were able to eliminate our sticker device, we kind of did a swap, and it was almost the same price. So when I was able to show them the decrease in dressing changes, that we could eliminate one of our products that could create a skin injury with the sticker, because taking that off sometimes is difficult. There was really no argument made about it. In addition, it's funny, the companies that are promoting protecting your peripherals, the product that they have out there is a $6 patch, and the glue is not. So when they were telling my hospital we had to protect the peripheral, I said, I agree, we need to protect the peripheral. We can't afford to do this, but we can afford to do that. And I showed them the research and the data on the infection prevention and the 8-log reduction, and our products people were sold.
Matt, a question for you is, have you used glue on a Huber needle for ports?
That is a great question. No, I have not used it on a Huber needle for ports. No, yeah, there should be no problem, obviously, using it with that to seal that. Most of our port patients usually are in the infusion center, and it's the same day, but wouldn't that be great to not have to wedge that sponge in there?
Absolutely. Have you ever used glue on a power flow port? It's accessed with a 16 gauge needle for those of us that are not knowledgeable on a power flow port, but I have my opinion. I'll leave that one to you, Matt, at this point.
Wow. No, I haven't. Our oncology nurses are the ones that usually access the ports, but I can only think that when accessing with a 16 gauge needle, you would want the best securement possible, and either on the way out or on the way in, I would be using an adhesive if that was available to me. What about you, Judy?
Me too, 100%.
I mean, 16 gauge, that's big.
That's big. That's too big. Well, that's big.
That's a 5 French dilator.
Yeah, definitely. I would be gluing it up.
I would definitely be gluing it up. So Matt, couple more questions for you. Do you have to re-glue every 7 days, or does the cleaning solution cleaning solution interfere with the glue?
Oh, that's a great question. So yes, I put the glue back on with my dressing changes every 7 days. You just have to let the cleaning solution dry first.
Okay, thank you. And let's see, do I need to use CHG disc or CHG Tegaderm on top of the adhesive to offer antimicrobial protection?
Okay, that's a great question as well. It depends on your policy at your institution, but it was stated in one of the slides that the three products that the company offers, the Surgiseal, the Fluoroseal, and the SecurePort IV, are all the same formulation. Therefore, all the claims that each product has are included in all of the formulations. So you'd have to do your own research on that and then make your decision based on that. But there are many institutions that have replaced the glue. They have used the glue in replacement of any other type of end site protection. So, and their studies and their data are going to be released soon. And what I've heard is very positive.
And remember, you should never do anything that's against your policy and procedure. So make sure you do the paperwork first.
Correct.
Okay. So when doing weekly dressing changes, do you have to scrub off the glue and place new glue? And is the glue just at the insertion site?
Great question too. So it all depends if you're on what you needed. You know, sometimes it's one drop at the insertion site, and on day 7, you don't even know that it's there. Sometimes you had either for some reason to make a nick, or for some reason it was a larger French catheter and you needed a little more glue. But there's not much residue. That was usually the butyls. Remember that we went through the methyl, ethyl, butyl, and octyl blends. The butyls would leave like crystallized pieces on the catheter. The octyl is more of a smooth liquid type of glue, so you don't really notice it by day 7, in my experience.
Now here's a question I've heard many times about removal. So how do you remove it if there's glue on there? And then do you have to remove the residual glue on the skin?
Okay. Yeah, these are all, questions that I went through as well when I adopted it, and I thought, gosh, what is this going to be like? I've gone back on my neonates to make an adjustment in the catheter length an hour or two after I've applied, even the first application of the glue. And while it seals terrifically and does a really good hold, you're able to release that seal with enough pressure and pull. So I'm sorry, Judy, repeat the question.
I'm reading ahead, Matt.
Something to be.
It was really about removal and how do you do it, and then and after you remove the device, not just a pick, but any device, then do you have to remove the glue? Do you have to scrub that glue off the skin?
Right. So you don't have to scrub the glue off the skin. It sloughs off naturally with your skin as your skin develops, but no, it just releases. You can use any type of adhesive remover if it's attached to the dressing, or for some reason, is really held in there well. But in my experience, we have not had any complaints from any nurses on the floor that remove our dressings as to, what's going on, what's different. It just holds it very well, just like all of the other adhesive improvement products. This is just another type of improvement product that also seals, in addition to providing extra securement for both the catheter and the Tegaderm.
When I've used the glue, you don't want to scrub it off your skin. That's where you're going to get skin injury. It will just come off over time. In fact, I don't think you can scrub it off your skin unless you take the skin with it.
Yeah, and like I said, the octyl blend of this glue is such a pure glue that you really don't even see it. And again, like I said in my talk, put the glue on your skin and experiment with yourself. See what a drop looks like. See what it feels like to use your adhesive remover at your institution on a dressing on yourself before you figure it out on a patient. Figure this out on yourself and on your teammates. This isn't an experimental, thing. And then you'll be able to, with confidence, apply and remove the product because you'll have played with it on yourself first.
We still have a few more questions. Are you available to stay on, Matt?
Oh, sure.
Perfect. Okay. So this one's very similar, and I think you already addressed it, but I just want to make sure specifically our folks get their answers. You've placed your line, and then after getting X-ray or verification, you found out your line's a tad too deep. How do you adjust it?
Okay, simply the same way you would adjust your line if you didn't use the adhesive. If you simply pull on the line with, a tiny bit of pressure, you will release the seal and be able to adjust your catheter. You're not supposed to put a gallon of the glue on so that you create a wall of protection. It's a drop to seal the exit site. And I think that is, something that you'll get a feel for when you start using it as to how much you need. And you just need, a drop or two at the insertion site, a drop under the catheter hub, and, I paint around the catheter just to adhere the tegaderm. But it's not what you think of like crazy glue where you're not going to be able to, get something off of your skin. It releases. It just also holds. But it's not like cement.
So question for you is, does your team do all the dressing changes for all central lines? If not, do staff nurses apply the glue when the dressing change is needed?
So that's the phase at my hospital that we're at right now, where we've gotten approval to replace our securement device, and we would be putting the glue into our central line dressing change kits for the nurses. And right now we're in the process of building that with our kitter. So yes, the nurses will be applying it. Our nurses in pediatrics use the glue already because it's a smaller, more contained unit than we're a 700-bed trauma center, so the adults portion of our hospital is much bigger. So to answer your question, it's coming down the road in my hospital, but a lot of hospitals already have them in their own kits, and you don't even have to have a specific manufacturer. Whoever makes your dressing change kits can, add whatever components or take out whatever components, you'd like in those kits.
Another question I've heard a few times: won't the disc be blocked, the effectiveness of the disc be blocked by the glue from doing its job?
So that's the beauty, right? That's the beauty of what I'm doing at the hospital now. My infectious disease physician agrees with me using it for a sealment to prevent bleeding. But without more articles out yet, he's hesitant to replace the patch. But what he acknowledges is the patch is deemed ineffective because the glue is under the patch. So he agrees with the data, with the infection rates, with the improvements that we've seen with the glue. But some institutions are very, very strict with publication and research prior to them making a drastic change in practice like that. And he's just waiting. He's waiting and watching. And we have, when I say we, I'm watching these other institutions that are going to be coming out with these great studies and publications on their use of the glue in replacement of any other protective device. And as you can see, I mean, it kills every piece of any kind of bacteria within 3 minutes. So it's fantastic. And I'm looking forward to the day where that's all you do. You put your catheter in and you seal your site and you secure your catheter with this invisible, beautiful liquid.
Your ID doc must be having a time with you, since he wants data before you change practice and you like to lead practice, but that's a whole nother subject. So how often do you need to reapply glue?
Every 7 days. Or every dressing change, or if you do an early dressing change.
Now, I'm not quite sure I'm understanding this. Oh, I do understand it now. What brand do you use? And is it something currently in stock at most facilities, i.e. in the OR? So
I understand. Are they asking what brand of glue?
I believe so, yeah. And
Okay.
There's only one glue marketed that is FDA cleared for vascular access. And if you're not unsure, since this is a CE event, it is from the sponsor of this webcast or this webinar. So if you go to Adhesion or Secure Port IV on the web, you will find the information on that one. Sorry, I took that one from you, Matt.
That's fine.
Can you reapply the adhesive after a 7-day dressing change? Yes, you've answered that one. And what dressing do you use on a patient who has had skin that will not allow the dressing to adhere, even when skin prep is used?
What type of dressing do we use?
Yeah. So what dressing
Well,
do you use on a patient who has skin that won't allow the dressing to adhere?
yeah, there are a bunch of, options out there. I don't want to go into brand names, but there's, there's dressings that are specific for, burn patients and Stephen Johnson syndrome type of patients where there's kind of a mesh type of product that creates a barrier between that and the adhesive. There's a lot out there. I would advise you, whoever is asking that question, which is a great question. You should always have these products on your cart, to look at your adhesive companies, your transparent membrane, dressing companies, and ask the other options that they have available, because there's a lot of them on the market.
And definitely get your wound care folks involved. They're
Yeah,
going to know.
they're great. They're great. They're the ones that found the adhesive remover that I like to use on the adhesive. So, wound cares, they're wonderful. And this is again like that puzzle I described. Why aren't we working with wound care when we're creating a wound in a patient every time we puncture the skin? So, that's another great resource.
Here's another great question for you. Do you use glue as a standard of care for all central venous catheters in the hospital, in pediatric use, or do you use them as needed in different situations?
My team uses the glue on every catheter from peripheral to central to tunneled. The hospital anesthesia and critical care, staff that place central lines in the hospital have not adopted its use yet. But my team, which does a larger percentage of all the catheters, yeah, we use it on every single insertion from pediatric to adult.
Okay. And the second part of her question, is, do you use a sterile product to remove the glue? And you've already mentioned you don't remove glue; it sloughs. So
right.
The question was actually, I might have missed it, but are using the same type product commonly known as Dermabond? The answer is no. And the product he uses is sponsored by the company that's doing this talk. So, can I get the glue in a sterile package to drop on your sterile field? Boom. Your
Yes.
answer. Good. It
come,
is.
Come in a really nice blister pack now, which is really easy to drop into your field.
Okay. We're going to go for a few more, and I know we've kept you on the line for a while, so thank you so much. Is it a one-time use, single patient use?
Yes.
Perfect.
One and
I may have missed in the beginning, or not sure why you're not using the name of the product. He can't use the name of the product because this is a CE program. The name of the product is in the first slide, not his slide, but if you look for Adhesion Medical, Biomedical, they have sponsored this program today, and they can get you as much information on this product as you're interested in. Obviously, you support this product and its use. Are there any concerns or downside? What a great question.
a downside to using it?
Yes.
There's no downside that I've experienced or found. There's been no reported skin injury or burn to the MAUD database or anything like that. There's been no complaints to the company thus far. I check in with them to ask. This is the same type of product that surgery has been using for years and years and years. This isn't like oh my God, Matt's using this great new product. We're just simply applying what everybody else has been using to vascular access. And it's just a shame, I think, that we haven't done this sooner. So there's no, it's just like, using a cleaning solution, using, any type of protective device, any kind of barrier, sealment, or adhesive product. There's no risk, unless, of course, for some rare reason they have an allergy to whatever happens to be in it. But I haven't experienced that yet.
And we're already greater than an hour into it. It's a 1 CE course. So I'm getting so many questions about the name of it. So CE portion's over. And the name of the product is Securement IV by Adhesive Biomedical. So I will give that up on that one. What if the patient is being discharged same day and only needs an IV for 24 hours? Do you still use glue?
They just need an IV for 24 hours. If they're going to be discharged, I do use the glue, because that's the 24-hour that you don't want to come back in 12 hours. So that's the patient that I'm going to secure the best, just to make sure that they don't come back, before that 24-hour mark. So yeah, it's, when you start to use it, you start to understand that it's not as big of a deal as it was. I used to go back and forth with Marsha Wise when she started talking to me about the glue, and I said, no, it's not needed, it's not needed. But when you can stop the pistoning of the catheter, and when you can secure that IV, especially in pediatrics and fragile skinned adults, it really makes a difference. It's like using, the type of tegaderm that you like. Do you use the regular standard one, or do you like the ones that have a couple of stickers on them, different pieces? It just really provides you that safety and securement that you and the patient need, I feel. And if all the other glues came in a small applicator and were that pure of a product, we'd be using that. I don't think it's the product as much as what the product does that we need in vascular access. And this happens to be the only FDA approved product for vascular access. So how can you not use it?
So Matt, I'm going to challenge you. I love you to death, but you said especially for pediatrics and fragile skinned adults. I'm not neither one of those, but I want it on my device. I don't want it to piston on me either.
Well, of course,
We're
taking the extremes. That's the cover and the end cover of the book, the pediatric and the adult, and in the middle are all the happy chapters of normal people that want to keep their lines in as well. And even silly things you don't realize if you watch like Andrew Blummer's flow studies, and you see how much pressure these IVs take when they go through a CAT scan, things like that. They get shot back. I actually flushed a line on a neonate once, and I shot the catheter out of the patient. This was during the insertion when I was trying to flush it down from the jugular, because it was only like a 5-centimeter line. But you don't realize how much force these catheters actually take. So to secure even better at the insertion site and prevent the pushing back and forward really does make a difference. Decreases the phlebitis, decreases the risk of colonization, and introducing that into the body. It's just kind of, for me, it's a no-brainer. Why wouldn't you seal it? Why wouldn't you seal the site?
So we have just a couple more questions here, so hopefully we can get through those for you without you having to head out. Have you seen any issues with skin abrasions or tears when you remove lines?
I haven't, because I don't overuse the glue, and I also, when I'm removing it, remove the dressing carefully as I would any other dressing that I used. And as long as the CE portion is over, if I used Cavalon or Mastisol, do you ask that question with Mastisol? Do you get skin tears? No, they use Detachol. So if you're going to use any type of securement, you should use whatever type of de-securement on the market is available to assist with removal. It's not this magic device that goes on and comes off without help. Every device even a regular tegaderm alone, I use a wipe to loosen the grip on the outside when I take it off to prevent a MARSI, a skin tear injury. So you have to use your critical thinking and judgment when you're removing the catheter. And if you see that it is sticking, then you use an adhesive remover.
Couple more questions. So getting a new product into the hospital can be a challenge, as we all know. Does the company provide samples? And Matt, can you answer that? Or I can refer them over to the company.
Well, since I don't work for the company, mine is speaking about what I do. I could say you could have free product for the rest of your life, but no, I'm sure if you call your rep, they'd be happy to come over. And give you a couple things to play with. That part I can't speak to, but if I were the hospital considering using a new product, I would have a business plan in place prior to using it. And I would go then to the company and say, look, this is what we want to do. This is how we want to evaluate it. Would you be willing to support that? And any company with any integrity, within reason, they're not going to give you a year supply, a 6-month supply, but any company with any integrity would support your due diligence to evaluate the product. So you can blame me and say, Matt said they'll help you out a little.
I love it. So you guys are treaters.
I do want to say one other thing. Sometimes you will get just a small ring around the insertion site because you are sealing the site, and if you do pull that back, it gets pulled back like a centimeter when you're doing a dressing change or whatever. That glue has already been crystallized, and you don't have to worry about that. You don't have to scrape it off. You don't have to do anything with it. You just reapply the glue at the insertion site, and that glue is hardened and nothing will happen to it because it's already done what it did. It killed everything. So sometimes in a rare instance that you get migration through your dressing change that you, the clinician, caused, you would just reapply at, a centimeter above.
Perfect. Thanks, Matt. One question here. I know a couple people have to go. Anybody that is looking for CEs, you will be getting an email within the hour, give or take, about taking the survey for the CE, and then you will get the CE via email directly after that. So Matt, we have 2 more, and then we're going to call it for the day. So does it just release as a matter of a few hours or minutes, or if you have to remove the line soon after placement? I think you've addressed this a few times. So I'll let you go one more time on that one.
Yeah, these questions are great, and I really think it's important that you experiment on yourself first, so that you can answer these questions before you get in a situation where you are with a patient. Glue one of your spare IVs to your arm, and then pull it. See what happens. See what kind of adhesive remover you need to use. See how much you need to use. See what it's like at 1 hour. See what it's like at 2 hours. It won't damage the skin. The seal that it creates is strong, but I've never seen it, pull skin off or anything like that. But I'm also gentle, I don't rip things off either. So, again, it's just another way to protect your catheter.
And you have to think about this as well, as it's cleared for neonates to 120-year-old geriatrics or greater.
Well, the oldest that I've used is a 107-year-old man with skin breakdown for his central line catheter. 107.
Yeah. And last question. I think this is a great one for the end of it. Have you seen a reduction in CLABSI or central or catheter-related infections?
At our hospital, we've seen a reduction in our central line / PIC line infections, but the caveat to that is I started doing a lot of tunneled catheters as well. So we've been moving away from our PICs to tunneled central lines, and we have a lot of different factors involved. So I can't pin it all to one thing, but what I can tell you is this: we're not returning for dressing changes. We're not having bleeding. We are not having catheter migration. And we do have a drop in infection rate. So whether it's the glue plus finding the right exit site location for our catheters, it definitely has played a role, and it's been really a game changer for my team and our staff. I want everybody that's left on, there's like 229 people left on. Guys, just think about it. If you take the product away from this and you think about vascular access, we're puncturing the skin. You know, I know that slide is still up with Dr. Ledun. Dr. Ledun says that the skin is the barrier to infection. It's his favorite line. I think he uses it to pick up his wife or whatever. My point is this. My point is this. Look, if you're going to break the skin, you should seal it. If you can seal it, you should do it. And if your sealant that you can use kills bacteria and prevents migration and catheter stabilization, how can you go wrong? It's just common sense at this point. It's not about the product. It's about what we need to protect our patients. And that's why I'm kind of passionate about this one. So thank you guys so much for joining us today.
Well, Matt, thank you so much. You are awesome. A great presentation.